covered, one piece, and don't have to be cleaned out ever. And you never climb this ladder again.
Don't kid with COVID. M Health Fairview wants you to know that what you do today will affect your family and our community tomorrow. Did you know that unchecked, COVID-19 can have a multiplier effect? On average, someone who has the virus is likely to spread it to 2 more people. In no time, those 3 become 15. 15 could jump to over 60 and so on. Wash your hands, avoid big groups, stay home, don't go out. We've all got to do our part.
Got it?
Got it.
It's slippery.
Yes. Quick! The quicker picker-upper. Bounty picks up messes quicker and is 2 times more absorbent than the leading ordinary brand.
Hey, look. I got it.
Bounty, the quicker picker-upper.
CBSN Minnesota. It's free and always on.
Scores and highlights. Streaming free across devices 24/7. CBS Sports HQ.
Cities and towns have spent the past few weeks making plans, adjusting them, and trying to help people affected. Prime example, St. Paul. Hello, we are breaking into programming for the Department of Health daily COVID-19 briefing. Let's listen in.
If you require any further assistance, please press *0. I would like to hand the conference over to your speaker, Mr. Michael Schumer. Please go ahead.
Thank you, operator, and thank you to everybody for joining us for a slightly downsized daily media call today. Governor Walz is not on today's call as he observes Good Friday with his family. Our lineup will start with Minnesota Commissioner of Health Jan Malcolm making some brief opening comments and talking about some of our latest case numbers. Following that, we will open it up for questions from reporters on the line. We do have Infectious Disease Division Director Chris Ersman and State Health Economist Stefan Gildemeister on the line for questions that you might have. So following that, we'll open it up now with Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. Thanks. We appreciate having a chance to spend more time with you today on some of the health-related questions. I will begin just with the same kind of data update that we've been doing in recent days. Globally and nationally, the context is that the global total of cases as of early this morning was over 1.6 million cases and 96,000 deaths. In the United States, we are reporting just over 466,000 confirmed cases. 162,000 about of those cases is in the state of New York, a little over 87,000 in New York City alone. The United States is reporting just under 17,000 deaths, over 5,000 of those in New York City alone. Here in Minnesota, we have now a total of 1,336 confirmed cases in our state, which is up 94 from yesterday's total. But again, the rate of growth continues to be fairly stable. So we're going up at about the same pace each day, with the doubling time still around 8 days. So, unfortunately, sadly, again, we confirmed 7 more COVID-19 deaths yesterday for a new total of 57 in the state. 2 of those individuals were in their 60s, 3 in their 80s, and 2 in their 90s. 5 of the 7 were residents of long-term care facilities. On the hospitalization front, there are currently 143 patients currently in the hospital as of today. That's actually 2 less than yesterday. 1 additional person was admitted to ICU. 3 were discharged from a non-ICU level of care. Also, as of today, 732 patients have been released from isolation. I would like to just make another comment about the mask situation. Just as we've been saying in recent days, there are lots of questions about the increasing CDC guidance that wearing masks in public is a helpful strategy to help slow the spread of the disease. And as we've been saying, if individual Minnesotans have or can make homemade cloth face masks for themselves, for their families, and for others, to please consider doing that. We have a lot of folks out there who are creative and good sewers. If people are in a position where they can help make homemade cloth face masks and donate them, some particularly good places to donate them would be to your local child care facilities, nursing homes, or other community organizations. As we've talked about, masks really can be helpful in protecting us from each other. As we've been saying, if I wear a mask, I'm not doing that to protect myself. I'm doing that to protect you from me in case I have the infection and don't know it. Because if I know it, hopefully I'm confined to my home. But I can wear a mask to protect you from the potential that I may be an asymptomatic spreader of the disease, and you can protect me by you wearing a mask for the same reason. So we've been trying to get that message out there that the masks are helpful for preventing spread in that way. They are not medical grade equipment. They are not personal protective equipment. And we really need to preserve those medical grade masks and equipment for direct patient care. So that's why we're emphasizing so much that there are a lot of us who work in public settings or who go to public settings for whom wearing masks is very helpful to prevent the spread of illness. But we really, really need to conserve and reserve that higher grade medical grade masks and equipment for those who are doing direct hands-on patient care. A lot of folks, even in the healthcare system, are providing important services, but not doing direct patient care. So back to the plea for people to make masks and donate them. If you have that skill, that time, that ability, be a wonderful thing to do. And please, but if you're thinking of donating it to a specific facility, it's a good idea to call ahead to be sure the facility can accept your donation at this time. But certainly if they can't, others can. So for more information on how to sew cloth face masks, for pattern ideas and materials that are recommended, please go to the MDH website. There is a face mask icon on the right-hand side of the page. The Centers for Disease Control and Prevention website also has this information. Most fabric stores have online ordering and curbside pickup options, so it's possible to order the materials that you would need for such a project, but still maintain social distancing guidelines. That concludes my comments for the day. I will see, and as Mike said, Chris Erzman and Stefan Gildemeister are both on the line with me. I think folks are aware that we've been rolling out increasing amounts of information about the analytics that we've been doing, the modeling with the School of Public Health. So Stefan is on to help answer questions about that. And Chris, of course, with her great depth of knowledge about what's going on with the epidemic in Minnesota. So Chris, unless you have any other comments you want to make at this time, we can open it right to questions.
Nope, that sounds great.
All right, operators, we're ready to take questions.
Thank you, presenters. And at this time, you will need to press *1 on your telephone keypad if you would like to ask a question. And to withdraw your question, press the # key. Please stand by while we compile the Q&A roster. Our first question comes from the line of Bill Werner of Minnesota News Network. Your line is open.
Thank you, and thank you, Commissioner and Mr. Gildemeister, too, for the excellent presentation earlier. It's very helpful. Thank you. I want to clarify a couple of things. Just very quick questions, I think. On the fourth scenario that you laid out, extending the stay-at-home order for all by 4 weeks, am I correct in assuming that means beyond what the governor's current extension is out to May 4th? And the second part of my question deals with one of your other slides. It says deaths in Minnesota may be due to clustering in congregate setting. The shape of the curve could change considerably over the next few weeks. Are you saying that they're, well, please clarify that. I guess my question is, are you saying that that we could see additional deaths pop up or the rate could increase as the virus moves beyond congregate settings? I may be drawing conclusions, but please enlighten me on that. Thank you.
Sure, Bill, I'm going to turn that over to Stefan, and Chris probably will have some perspective on this too, but I just by way of, again, background, yeah, I think your question just really it illustrates another important point, that the model wasn't built to predict a specific outcome, nor have we tried to model precisely what the governor's order was. And Stefan can describe why they chose the specific scenarios that they did, all of which are hypothetical and just meant to illustrate the relative impact of different strategies. So go ahead, Stefan. And Stefan, you may be on mute.
I was on mute. Thank you for the tip. Thank you, Commissioner, and thank you, Bill, for the question. So that's exactly right. The way the scenarios were structured with the help of the scientists at the university was to build them in a way that we can explore iterative mitigation strategies and better understand their relative impact on some outcome measures. Mortality, time to peak, infection, days till the ICU reaches a maximum capacity. So it was one element that the governor would have considered, but we were not designing something for the governor in particular, but rather to inform the discussion. To the second question, I apologize if the limitation section was not particularly clear. What we're trying to say is, if the infection continues through community spread, what matters is where it happens. The R naught, the degree to which the pathogen is passed on, is a function sort of the contact that individuals have. So in congregate settings, as we've seen in Washington, it can move much faster, and the curve could be steeper. So that is what we're trying to say. Depending on where the pathogen moves through the population, the speed at which it's passed on could change. Our assumptions are fairly basic, driven by the evidence in the literature, and not designed to predict what would happen if particular hotspots would emerge. And maybe, Chris, you have some additional insight that you'd like to share on that.
Well, I just was going to comment that, you know, as you've probably noticed, we are seeing a lot more activity in congregate care settings. But I want to acknowledge that, you know, we have prioritized testing for that group, because we know that it's a group that is very high risk for complications of COVID. And so we want to make sure that we are aggressively intervening when we can. And so, you know, we are focusing on that population, and that is also skewing our data a bit, because we're seeing more and more cases in long-term care, partly because that is where we are focusing some of our testing. And it's important that we do that, but I want to acknowledge that that does not mean that there isn't transmission that could be happening in the community, but the testing that's being done is being focused in some of these other settings.
May I just do one quick follow-up, and that is in regards to the issue brought out in the scenario number 4. Is it reasonable to, when we're writing our stories, is it reasonable to conclude that if we were to extend the stay-at-home order beyond what's currently enforced for the most vulnerable in Minnesota's population only, that we, according to the model, now these are predictions, I understand, that we would potentially see a significant decrease in the mortality? Would that essentially be accurate?
This is Commissioner Malcolm. Yeah, I think that's certainly something that most of the models that are out there agree on, which is that given the much higher risk of severity of disease among folks with underlying health conditions, and particularly those of a more advanced age with underlying health conditions, that is one of the bigger factors that predict the need for hospital care and intensive care at that. So I think the degree to which we all understand that it's going to take quite some time for immunity to build up in the population, the so-called herd immunity that you always hear us talking about, and it's going to take quite some time before there's a vaccination to prophylactically equip people against the disease. Trying to keep people who are more vulnerable to really severe cases of the disease from being exposed to people who quite possibly have the disease, even if they may be very minimally symptomatic or asymptomatic or pre-symptomatic, that is going to be one of the ways that we try to protect people going forward. Now, how exactly you do that and what that means to say continued social distancing for the highest risk groups are some of the things that the governor's got teams of people looking at what might such a strategy look like.
Thank you all. I apologize for taking so long, and to the other reporters too. Thank you.
Your next question comes from the line of Mariel Moss of WCCO TV. Your line is now open.
Hi there. Thanks, Commissioner Malcolm and Chris. Just was wondering, where do we stand as a state in getting antibody tests for people who live here?
Well, I think this is Commissioner Malcolm, as the governor has said, that's while we feel like that being in Minnesota with Mayo being in such a leadership position on the developing of antibody tests or serology tests, that we hope and expect to be taking advantage of that technology or that new testing ability as that comes online. So yes, that's going to factor into our going forward strategies about how do we build up testing. We've talked about there's the diagnostic testing, the PCR testing that we've been doing so far, and supplementing that with rapid point of care testing and the serology testing to help us determine when someone's already been infected and recovered and developed antibodies. But Chris may well have some deeper knowledge than I do about kind of where that serology testing is in the pipeline.
Well, yeah, this is Chris. The one thing that I want to just add is that there are different layers and types of serology testing that are available. And so the governor has a team that has been looking at laboratory testing. And last night we heard from Mayo about what they're doing with their serology test, which is wonderful. But there are dozens of other manufacturers who are putting serology tests on the market. And, you know, whether or not these will be FDA approved and in what settings they're appropriate and things, I think it's important for people to recognize that there are multiple different types of serology tests, and they will not be at the same level in terms of our confidence in their results. And so we are looking to work with Mayo and how we can use serology going forward. But I think it's important for the public to realize that not all serology tests are created equal. And so we want to make sure that the testing that we are promoting to use in Minnesota is one that has been well vetted and validated. And certainly Mayo is doing that.
Thank you so much.
Your next question comes from the line of Kent Erdal of CARE TV. Your line is now open.
All right, thanks a lot. Quick follow-up first, because I don't know that it's super clear on the scenario 4 that was talked about today. The timeline that 4 weeks entails, I took it as meaning extending for another 4 weeks, similar to what we've done now. And I know another reporter had just said that they took it to mean extending beyond May 4th by another 4 weeks. Can you describe that? Because that obviously impacts some of the dates after that.
Stefan, go ahead, but just again to remind remind folks, scenario 4 is not exactly what the governor announced yesterday, but Stefan, you can just clarify the starting point for the model assumption.
Thanks, Commissioner. Happy to. Yes, so scenario 4, another hypothetical scenario, extends the initial 2-week order by another 4 weeks to a total of 6 weeks.
Okay. And then I know that this has been talked about beyond the hypothetical models that the governor had kind of laid out beyond any kind of stay-at-home order, that the vulnerable would be protected. I know that scenario 3 talks specifically about just extending a long-term stay-at-home for the most vulnerable. Can you tell us, has there been discussion about what that would really kind of look like and who is considered most vulnerable?
Well, as I mentioned on an earlier question, that is the subject of a lot of discussion and planning work right now, is what would a longer term protective strategy, minimizing social contacts mean for more vulnerable populations. For the purpose of the model, Stefan clarified in an earlier discussion that the model defines vulnerable population as those over 60 with further layering in what we know about underlying chronic health conditions, specifically the incidence of those conditions in Minnesota, which makes our model, we think, valuable to us, specifically locally. So that model kind of takes into account age over 60 and underlying conditions. And in terms of how would one achieve that longer term, greater level of protection, minimizing social contacts for those vulnerable populations, again, that there's a whole work team thinking about what that would mean and how that could be done.
Quick follow-up on that, long term, what does that mean in terms of that scenario 3 for time length?
Stefan, maybe you can clarify that. It was really intended to be until some days after the peak infection rate in the population as a whole had passed.
Yeah, Commissioner, thank you. That's exactly right. So the thinking of the research team in sort of designing this scenario was to ask what's a time point that is not a recommendation at all, but is sort of one way of illustrating what would happen if individuals had a higher risk of hospitalization, ICU care, and mortality were protected from the virus, essentially by not being in its way and staying at home. And sort of what we the way we put this together was to say 30 days after peak mortality has been reached. So we wouldn't, in this scenario, think about releasing individuals once we're at the peak, but rather once we're in a declining stage of the epidemic, at least as far as the data and the assumptions tell us. So I think in this scenario, at minimum, we assumed 10 weeks, depending on the scenario. This can easily turn to 14, 13 weeks or so. So the peak is a function of the mitigation, the response, and essentially those two factors.
Thank you.
I'd just like to jump in and just with Commissioner Malcolm again, just with the sort of further comment. I know you've heard this now several times for us, but just we can't say it often enough that the model is one, we think, quite valuable tool in helping to understand the relative impacts of different levers, different impacts of trying to mitigate the health harms of this epidemic. But it's one among many variables, and we are also looking at other epidemiological data to inform differences in how the epidemic seems to be unfolding among different parts of the population. So I just again want to restate that yet another time, is that we'll be looking at a lot of different factors and a lot of different considerations in addition to what the model suggests might be some of the impacts as we look further down the road.
Your next question comes from the line of Peter Cox of Minnesota Public Radio. Your line is now open.
Thank you. I'm wondering if there are any hotspots the department is watching closely and where those are. And kind of along the same lines, wondering how closely you're watching the Smithfield food situation in South Dakota, and if there's a worry of possible spillover into Minnesota, what you're doing about that at this point.
Thanks. Chris, I'll turn that one to you.
Sure. In terms of hotspots, I would say that the area that we're focusing on most heavily at this point is our congregate care settings. We are now at 82 facilities that have had a case or an exposure within their facility. And so we're working very closely with them. And we have seen several facilities that have had, multiple cases within a facility. So we do have some hot spots in that regard. And then we're aware of the Smithfield situation, and we'll be continuing to monitor and see if we develop, any cases in that southwestern part of the state.
Your next question comes from the line of Emily Havoc of Care 11. Your line is now open.
Hi guys, thank you for taking my question. I want to clarify something I think I heard in the 11 a.m. That we're estimating we have 10 times the cases that are actually reported as confirmed. I know that we said that's the tip of the iceberg, but I think that was the most specific figure I've heard. So can I just clarify if that was the case? And then what would that mean for the percentage of cases that we believe are hospitalized in an ICU? Is that still the 15% and 5% we've been hearing?
I think Chris and Stefan, I'll ask you to talk about the math of this, but I think it's one of the things that we've said is introduces such a wide range of potentially different outcomes depending upon what you conclude about the case detection rate, or what percentage of the actual cases are we finding through testing. And we know the sort of the circular nature of the problem of the limitations on testing, and Chris has made the point that we've been focusing the testing on particular populations, anyone who's hospitalized and those in congregate settings and healthcare workers who are ill. And we've been testing there because those are the places that we need the fastest interventions to be able to support people's course of care, but also to try to contain the spread. But the limitations on testing, although we've shared with you some data that suggests that we're kind of in the middle of the pack on how much of our population we've been able to test, and still look reasonably toward the top of the pack in a good way in terms of a lower percentage of tests that are positive. But I think Stefan, I heard two numbers this morning, so it'd be helpful if you would clarify I've heard 1 in 10 and 1 in 100 in terms of what you think the actual case detection rate is. So maybe between the two of you, you can just continue to kind of bat that back and forth, because it's still, quite honestly, it's still a discussion internally.
Yeah, I'll take a crack at this. So what we assumed based on evidence in the literature was a case detection rate of about 12%. But when we aligned the model with the actual observed number of deaths starting in late May, what we realized is that the epidemic is much more widespread than would be apparent with a case detection rate of 12%. So adjusting the model to fit the data tells us we're much closer to 1% detection rate. So to turn that around, if you multiply the number of confirmed cases by 100, you get closer to what we expect the actual number of cases are in the community. And to give a shout out to Chris Harrisman, she's been saying this for weeks, and now we have the data to sort of confirm that.
Thank you, Stefan. One thing that I wanted to add is just that I think we've been focusing, as I said, we've been prioritizing our testing, and when we started to prioritize, we explained that the reason that we're doing this is we want to make sure that as much as we want everyone to be able to be tested, we want to make sure that we have testing available for the most vulnerable, as well as for those individuals in those situations in which having test results would make a difference in their care. And so hence the prioritization with our testing. But I want to acknowledge that while we're testing in these congregate care settings, the introduction into these settings is from the community. So the spread that we're seeing in congregate care is simply an extension of what's going on in the community. So I want to acknowledge that we're not getting the number of cases that are, kind of classified as pure community spread, but what's happening in congregate care is an extension of what's going on in the community. And then just looking at our numbers right now, we've got 20% of our cases ever hospitalized, and 4% of our death rate, or our deaths are at 4% of the cases that we have identified. So even with our very focused testing in the highest risk groups, we're still within the parameters of what's been seen globally.
Thank you. And can I just also follow up? So the model that we saw today is based on 2,200 ICU bed capacity, and we already, it looks like, have over 2,700 either present or ready to go. So can anyone talk about how that would change the projections, or is that, I understand that this is not about specific numbers, it's more about direction, as you guys have said, but still interested to see how, and assuming that ICU capacity will even go up past 2,700 as the state is hoping. How would that affect the peak and the mortality rate?
Yep, I'll let Stefan answer how that would show up in the modeling results. But a part of your point, and you're right, we're tracking with real-time data from the healthcare systems around the state what their bed capacity is. So how many beds could be are now ICU beds, how many can be converted to ICU beds. But the other critical variable is the ventilators and the staff to staff those. But there's also the assumption that, of course, not all of the ventilators or the ICU capacity is going to be used for COVID cases. So I think the model makes an estimate that of the total number of ICU beds that we're reporting elsewhere in the dashboard, that some number of those will not be being applied to the COVID epidemic, but for other purposes. But Stefan, would you want to say more about how that plays in the model?
Yeah, maybe 2 quick points. So the way mortality with this disease works is that one mechanism that we worry about, of course, is that individuals who are in the ICU and require a machine to help them breathe, if they don't get that machine, if they don't get that level of care, their risk of mortality, which is at a base level already not zero, their risk of mortality increases tremendously, and it increases much higher for individuals in an old age. So we do worry about appropriate ICU capacity that has meant capabilities, essential machines that help us breathe when that's necessary. So as that capacity goes up, mortality could shrink. So we have not modeled anything beyond beyond 2,200 ICU beds, but I think I can say with confidence, without having done that, as capacity goes up, mortality would shrink by some fraction of the current estimates. The other point I wanted to make, sort of to illustrate what the Commissioner has been saying, we can't expect that all ICU beds are going to be available to COVID patients. There's continued need for health care for people with chronic conditions, for people who have acute healthcare needs. And sort of for this model, we've made a very blunt assumption to say about 500 of the surge capacity that we are planning for right now for the immediate future might be needed for other patients. To the extent that we are erring in that assumption, our estimates of mortality would either be high or low. But then again, it's also important to remember that the estimates of mortality in the first place have a really large amount of uncertainty around it.
Thanks, everybody. Your next question comes from the line of Sayogit from Fox 9. Your line is now open.
Hi, everybody. I have a couple of questions about the slide deck that was presented this morning. One of the key takeaways I had was the differences between your model and the IHME model is that it goes out much further. Your model goes out much further, and you're talking about potentially more than one peak. Yet on the slide deck this morning, which went out 30 weeks, there was only one peak shown. So are you guys forecasting a second peak, a third peak? Would it be after the 30 weeks yet before the 16 months runs out that your model goes to?
Stefan, go ahead.
Thank you, Commissioner. So yeah, I mean, there are a number of takeaways around how the IHME model differs from Minnesota, but to focus on the question that you asked, the scenarios that we demonstrated are kind of static scenarios, and they assume different length of implementation. Clearly, the governor right now has made an announcement that covers a certain period of time, and depending on how that changes or how the governor decides of what comes after, the epidemic can shift differently from these sketched out static scenarios. So there's been a lot of talk about stepping on the brake of stopping the spread of the disease and then accelerating it again. So depending on the strategy of mitigation, the curves would shift or multiple curves would occur. So many have been wondering whether some of the communities that have seen in Europe and in China that have seen a slowdown of the disease, whether that is the last word or not. We don't know that, but for the scenarios we modeled, again, static ones, hypothetical ones, the disease comes to a very much slowdown within that 30-week window. We have modeled the disease through sort of a period of 365 days, and we can certainly show that in a different demonstration if that's helpful.
And then my second question for clarity, you already said what your definition of vulnerable people is. I'm also wondering, because in some of these scenarios, you model out a continuation of physical distancing to reduce contacts by 50%. What is the definition of that physical distancing?
Sticking with you, Stefan.
Yeah, thank you, Commissioner. When the assumption of physical distancing is consistent with the guidance and the circumstances that we had before the governor's stay-at-home order. So I'm not sure that I will have all the components at my fingertips, but it's essentially those school bars and places of congregation would be closed. The recommendation for groups not to exceed certain sizes. So it's not the stay-at-home order, but it is a mechanism to reduce social distancing by a considerable amount. I have to admit, though, that this is fairly uncertain science to the extent that we don't have a robust understanding yet, I should say, how much contacts would change or have changed under all of these orders. We sort of look at patterns of contacts between individuals across different age groups and with school children without, and sort of look at patterns of contacts and say, what happens if you close schools? What happens if you start telework? So it is an approximation of what contacts might look like. We're currently in the process of assessing that empirically by asking Minnesotans sort of how many contacts they have on an average day through waves of surveys. And that is part of that iterative science that we talked about this morning to make our model and our understanding of the disease and the mitigation more precise and more robust. So the output from it can be more informative to decision makers.
Okay, thank you. That's very helpful clarification.
Your next question comes from the line of Walker Orenstein of MainPost. Your line is now open.
Hi, everyone. Just one quick thing. Do you all have the number of long-term care, people in long-term care who have died out of the 57 deaths that we have in the state? And I also wanted to ask about, the governor has urged you and DEED to begin planning on how to let some non-critical industries go back to work. Can you tell me about how you will decide which industries to work on first? Is there some sort of prioritization system based on industry, the type of industry, or is it just, you know, whenever they ask you all for it? Just give us a little sense of how that work is being done and what your approach to that might be.
Sure. Excuse me. Sure. Chris, maybe you can answer the question first about numbers.
Yep. 36 of our deaths were in individuals in a congregate care setting.
So 36 of 57. Yep.
Yes.
Right.
Okay, great. And about the DEED stuff?
Yes. So as we mentioned, there is a work group looking at that across several agencies. DEED and the Department of Labor and Industry are kind of in the lead on that. We're sort of providing advice from a public health perspective on what constitutes safe social distancing, and we're kind of going back to the basic advice for some time now has been to try to minimize direct, close contact, which we define as kind of contact within 6 feet for more than 10 minutes at a time. So what kind of environments or what kind of practices would lend themselves to work environments, or commerce being able to operate within those parameters. So I can just tell you that, and I personally have not been on that work group. A couple of our colleagues are doing that, but that they'll be looking at, it's really about what types of environments lend themselves to being able to really practice that social distancing.
And can you say that industries that won't be able to follow the guidelines just described will not be able to go back to work, or is there any sort of flexibility around the edges? What does that look like?
Well, you know, we've been working on this within the construct of what are essential services, some of which we acknowledge cannot do social distancing, and those need to continue. I mean, healthcare being the classic example of that. Those need to continue, you know, for the protection of the public, despite the fact that they're not social distancing compatible, really. But that's where the use of personal protective equipment and stringent infection control, limitations on visitors, all those things become a necessary part of the strategy as well. So when we're talking about not only looking at things through the lens of those federal definitions of what's essential and what's not essential or less essential from a health, life, and safety perspective, what are those, again, those environments that do lend themselves to being able to function, but function safely with social distancing strategies. So I think it's, I don't think it's going to be exactly black or white on types of industries. It may start out that way, but I think the governor's overarching goal is pretty clear, is to figure out through appropriate guidance, but also technological assistance, what are the ways that we can get people back to work safely as soon as we can.
Thank you. Your next question comes from the line of Darren Stevenson of KTOE Radio. Your line is now open.
Thank you, commissioners. I know you guys aren't policy makers per se, but most of the policies that have been put in place since this pandemic came out had the goal of not overwhelming the healthcare system when a surge does occur. And part of the policies was delaying elective care and delaying elective surgery. But because of that, the numbers as of yesterday, over 10% of the Minnesotans that are or have filed for unemployment have been healthcare workers. Granted, the elective surgery and the elective care delay was well-intentioned. Nobody's questioning that, but in a unintended consequences sort of way, has that that policy that has been put in place perhaps hurt the overall ability to provide health care in this state with 36,000 healthcare workers on the unemployment line?
Well, it's a really good question. It's a tough question. It illustrates the hard trade-offs here. I think it's important to acknowledge that the suggestion that we needed to move to that restriction on elective procedures actually came from the healthcare industry itself as a way of doing two things, really: conserving personal protective equipment and minimizing the spread of the disease within their environment, and minimizing the exposure of healthcare workers potentially to getting the disease, in anticipation of the fact that that capacity was going to be needed related to the surge in COVID cases. So it made a lot of sense from the perspective of turning the attention to preparation for more intensive care capacity. But your observation is correct that at least in the short term, what that means is the healthcare workers who aren't directly involved in the current buildup of intensive care capacity are currently kind of waiting in the wings, so to speak. But I acknowledge that, very, very fair point. It may seem really counterintuitive why we have healthcare workers not working right now, but it's been in part, listening to the healthcare leaders themselves, kind of a protective strategy to reserve that capacity.
And just related to that, as you very well know, healthcare does remain a business to many people. Is there a fear that, especially in the rural parts of Minnesota, that hospitals will be put on such financial strain? And frankly, they are. Many would agree, even before this, there's going to be such financial strain put on especially rural hospitals that some may eventually cease to exist.
That is absolutely true and absolutely a worry. And I think the governor has mentioned that he's in regular contact with our congressional delegation, all of whom are very sensitive to this point and have already been talking about further economic assistance to the healthcare sector, to the healthcare delivery systems, is a big priority for the next federal bills. And not just about they need more money for COVID-related costs or COVID preparations, but they need financial stability of their core operations, just as you've just said. And so I think that there's a big recognition of that, and really that because of just the fiscal realities of the federal government's ability to just do so much more than we can at the state level, that shoring up the economics of healthcare delivery is an urgent federal priority that at least our delegation is well aware of.
Thanks for making yourselves available again. Appreciate it.
Your next question comes from the line of David Ulrich of Pioneer Press. Your line is now open.
Hi, thank you. First, I just wanted to get a suggestion to my friends in the media. If you're confused about the dates for these scenarios, because we keep asking questions, page 11 of the slideshow that is now online is where those scenario details are. And then I just want to follow up for Stefan to Theo's question. If I understand this right, the deaths that you guys are projecting under these various scenarios, and I understand their range of death, they are not encapsulated in the graphs that you showed. Is that right? Because the deaths go farther out in time than the curves that you showed.
Stefan, can you take that?
Yeah, I can give this a try. Dave, I think this is right. I don't have the data right in front of me, but sort of if I can refer you to the curves that we had shown, even sort of again reminding all of us that these are hypothetical scenarios. But even as the ICU demand decreases, mortality associated with COVID will likely continue to occur. But we can look at the data and share those numbers with you. For the purpose of illustrating this graphically, we just chose a window that was that seemed visually to work. But as I've said, we've modeled this out for at least a year, and that's where we differ with some of the other models, and the duration and the impacts or the outcome of the scenarios are covering that period. So more than 365 days or so.
Okay, thank you. And then related to that, if I understood the way this was responded to right in the earlier in the slideshow presentation this morning, if somebody looks at New York City right now and says, well, they don't even have 5,000 people in their ICU, why are we so worried about our ICU? The response is, first of all, New York has restrictions that we don't have, and we don't have that level of restriction. So if we don't get even stricter, our peak would be higher effectively. Is that right? In other words, when you look at New York and Wuhan and Italy, they underwent much more stringent restrictions than we're under right now, and that changes things when we look at their experience.
Stefan?
Thank you, Commissioner. Yeah, I mean, I come back to the talking point of saying with the data on the scenarios, on the disease that we are observing in Minnesota, this is the best estimate we are producing. So to the extent that that circumstances change in May or in June, our curve changes. To the extent that we have poor compliance with the mitigation strategies and the contacts change as a result of it, our circumstances could change. So that is where some of the uncertainty comes from, but it's also sort of where the healthcare industry is worried about being appropriately prepared for it. Sort of modeling this out in a static way, the way we're doing it, is an attempt to demonstrate likely outcomes under different scenarios. There are infinite scenarios, of course, and we've asked sort of others in the community as well as on the media, sort of what scenarios are relevant outcomes that we ought to consider modeling, including, as I said, I think early on this call, on-off strategies where mitigation stops and comes back. So that's one point about the peak. The other point I would say is, the peak is a function and mortality related to the peak is a function of how effective hospitals can actually, the peak is a function of how the disease is transmitted and whether all those assumptions are correct. But mortality related to that peak is a function of how well prepared we are to deliver the services that patients need and to protect the healthcare providers who are delivering care to these patients. So there is a lot of more evidence that we need to amass over the next few weeks to understand whether these peaks are too pessimistic or whether they are realistic outcomes. As the commissioner said, when the healthcare providers worked with a firm and their model, they expect the peaks to come earlier, but essentially be around the same level. So yeah, I'll stop there because I don't know that I can get any more clarity on it.
Operator, we have time for one more question.
That is noted. And your next question comes from the line of Adam Uren. Your line is now open. From Bring Me the News.
Hi. Just to let me get on. I'm just wondering, the figures that you guys have put together in terms of the death estimates, is that based upon the number of COVID cases that are being confirmed now? I'm just sort of bearing in mind that Commissioner Malcolm yesterday mentioned how there are a number of suspected cases that haven't been confirmed because testing has not been available. So I'm just wondering, to what extent is that factored into the model, if at all, or is this based solely upon the number of confirmed COVID-19 deaths that have been so far?
Stefan, maybe you can kind of go back over that point. It's very key. And my basic understanding is that the model does include an estimate of the total number of cases, not just the test confirmed cases. But go over that again, Stefan. Thanks.
Yeah, that's exactly right, Commissioner. Thank you. So maybe I'll take a step back to what the model actually is. The model is a mathematical approach to understanding how individuals in a community, in this case Minnesota, travel through different compartments of the disease. It's a fear model, the percent susceptible, the percent exposed, percent infected, and the percent recovered. So to the extent that we have only partial insight into actual confirmed cases, we have mathematical relationships to understand through incubation periods and the infectious period, the rate of transmission, the age distribution of the population, the comorbidity. We have a sense that helps us understanding what population at each stage is impacted and how they travel through these, so to speak, compartments of the disease. And then to fit the model to actual Minnesota scenarios, we, our colleagues at the University of Minnesota, ensure that the model aligns with the statistics that we are observing on confirmed COVID cases. So that's the long answer, and I'm sorry for the long answer, but the short answer is yes. The model outcomes include the cases that has not been confirmed through tests.
Okay, and just a quick follow-up to that then. So basically, based upon that, is it in the continued absence of testing, is it very likely that in the let's hope it's not what happens, but in the case that there are these 20,000 deaths potentially over the course of the pandemic, that number would not be reflected in the official death statistics for Minnesota?
Actually, I think we are very careful with death to appropriately assess whether they were COVID-related deaths. So I think looking at a death certificate data is sort of an independent variable. Chris, can you say more about that?
Yeah, looking at death certificates is something that we will be doing. Right now, the deaths that we are counting are deaths that are individuals who were COVID-19 positive by a laboratory test and have passed away. But we will be incorporating information from death certificates as well. And the commissioner went over sort of the details of how that's done yesterday. Does that?
Well, yeah, well, I'm just trying to understand, because at the moment I've received an email from your office today that says there are currently 6 cases in Minnesota in which COVID-19 has been listed as a suspected or probable cause of death for 6 people. And like you say, the Department of Health then goes back and asks whether testing has been carried out. What happens if the testing hasn't been carried out and it's based, it remains a suspected case? Would that be reflected in the overall statistics? Is what I'm sort of saying.
Well, as the commissioner said yesterday, only certain individuals can change the death certificate and what's listed on there. But we are obviously, for all the cases that are positively laboratory confirmed, we know we can say with confidence, this individual was laboratory confirmed and passed away. But yes, but that's true for many diseases that there may not be all the information that you would want absolutely listed on the death certificate, but that's part of why we're doing what the commissioner indicated, which is looking at syndromic surveillance and looking at other indicators that can help us get a sense of the bigger picture. And so that will help to inform our understanding, even if we have a situation in which someone, was not tested before they died. We may not have the exact numbers for deaths, but we will have a picture of what's going on in the state based on the case data that we have, the case death data that we have, as well as the additional syndromic surveillance that we're looking at.
Adam, and since Mike, I just wanted to follow up. We sent out some information about this very issue yesterday that I think I can forward to you and might address some of your questions as well.
And Chris and Mike, can I make one more clarification? So I think it's really important to make that distinction between what we know administratively about the disease and what we expect to understand through a model. So the model is independent of what's on the death certificate or not. It's assuming how the disease travels through the population with sort of the parameters of infectiousness, fatality, etc. Whether in the end we can tie those to what we know administratively, that's a separate question. We certainly are looking to inform the model with actual death, positive information on COVID through death records, and that's why looking at death records right now is a really important piece. But those are 2 different sidelines onto the disease.
Thank you, Stefan, and thank you to all our speakers. That's all we have time for today. I do want to make a quick note about weekend calls. At this point, we are not planning a call for Saturday or Sunday as we head into the holiday weekend. We will be providing an update of the cases along with the information that's on the website. We will be available for questions that you might have. And of course, we're available this afternoon for any follow-up based on today's information. With that, we will wrap up today's call. Thank you.
All right, that was today's COVID-19 briefing by state leaders. We learned